together weekly reports of who's prescribing, e-prescribing the most, and we actually got a little bit of a competition going at one point of people trying to out e-prescribe the other. So that worked pretty good too. And we'll talk about this more in a minute. Eliminating roadblocks is what we do when we go to these places. We want to really listen to what they're telling us and not, pass off somebody's complaints. And we try to stay really abreast of the e-prescribing news. It's all over the place. It's coming out every day in different sources that you read. So, like I said, we always try to pay attention to criticism. We want to know the pitfalls, and we want to identify them because we want to either try and fix them or we want to bring them back to, in our case, empower RXs. These are things that don't work so well. Actually, what we've done is we have eliminated the using the help desk for technology, and anybody who has a problem with any of it comes directly to ABH, and we take that and try to fix it, because I don't know about help desk at your various organizations, but sometimes they don't even answer the phone. So we've taken that out of the mix. Now I guess we've moved into some of the specifically identified issues as the project went along. As you pull down the drug list, there actually was no way to indicate the route of administration. I guess it was assumed to be all oral medicines. Well, some long-term medicines in psychiatry you give prescriptions for are given either IM or sub-Q. So we added that to the list of problems. There were problems adding patients to the manifest. It seemed to be a little cumbersome. I think at first we thought it might be updated with Medicaid data, but they were having a lot of times be entered by hand the first time. So there were some complaints about just getting a patient into one's record on their PDA. So we identified that as a problem. There were a lot of issues with pharmacies. I counted up, within a 5-mile radius of my house, there's a Walmart, 2 Walgreens, 2 CVS's, a Target, an Albertsons, and Sacred Heart Hospital. So with a with a Walgreens on every corner right next to a CVS, a lot of times the code numbers were wrong, and so we had some prescriptions going to the wrong drugstore, even though it was a CVS. And maybe CVSs communicate with each other, but that didn't work as smooth as we thought. There were some fax numbers that were wrong in the records of pharmacy we had. So, and still everyone kept complaining about duplicating. They would send it electronically, but then the medical record system that were implemented, they didn't exactly merge with each other, so there had to be a written prescription in the chart. And this was a big complaint of, why are we going to do this if we're just going to have to write it here, or why not? So we've been working on that. That's probably a systems issue with our electronic medical records and the other system. One of the other issues of duplicating work, we actually were able to fix that by showing folks how to use their favorites. You can, and this is where the accuracy comes in. You just drop it down and there's the correct dose of correctly spelled medicine, not handwritten. And so we found that part to be especially useful. Equipment failure, actually it wasn't equipment failure. One doc lost his PDA. And so we got him another one. And controlled substances. I've actually kind of talked about those two in the middle. Controlled substances is an issue. And I know these guys share the same thing with me. We have, as a mental health center, we have a significant number of children, and probably the most common diagnosis in kids is attention deficit disorder when they come to the attention of that. And Ritalin and Adderall, those can't be done electronically. And we see this for, especially pediatric psychiatry, is a big issue. We actually heard that you guys were talking about this may be way delayed, but we actually heard that the Attorney General's office, the U.S. Attorney General's office, was exploring this and trying to get Congress to move forward with changing this. And then there's a company in California who was more than happy to point out that they did secure information for the CIA and they thought they could do this. So maybe this is not years away, because this is really kind of a problem. The next part I'm going to talk about the RX Online Assistance Program, the ROPE part of the Empower RX program. This may be a problem for Lakeview Center unlike anyone else has. A ropes user is somebody who can access the system. They can enter patients in there. If they're a non-nurse, they really can't authorize refills. So like a pharmacist, for instance, is a non-nurse who can't authorize refills. And at Lakeview Center, the pharmacy sits in the middle, and all requests for refills go to our pharmacy. And then the pharmacy gets the approval for the refill, and they authorize it back to the drugstore. It just happens to be our point of access for a refill. Well, our pharmacists can't be ropes users, so in that case, it's almost like, well, why would I even open up the Empower RX program for refills? Because we got a big problem. So this was something that, I don't know how you guys do that, but this was actually a little bit of a stumbling block for us on that. And we've talked to Anil and to Empower RX about that part and the ropes users. And to be a rope user, the doctor has to allow you to look at his information and authorize you to do that, even if you're a nurse. Payer source, the only payer source we have access to are Medicaid right now. So as far as picking up prescriptions, we will know if somebody picked up a Medicaid prescription. We won't know if it was Part D or occasionally somebody has commercial insurance. It'll always just say pending in there. So there's a gap in what we can learn. And then there are fields that didn't necessarily need to be populated on every patient, and there were no defaults, and so without populating them, some prescriptions wouldn't go through because it was a blank on the interface sheet. So we encountered that some. The happy consequence for us is that Lakeview Center is a retail pharmacy, and it got entered into the database. So somebody could use us if they wanted to. We'd be okay with that. During the first 6 months, and this data comes from the Agency for Healthcare Administration and from Empower RX. Our 5 prescribers wrote 1,881 prescriptions, and those were 398 unique patients. And the average cost of a non-e-prescribed patient was $276, and the average cost of somebody who had an e-prescription was $228. So with a little simple math, we believed we saved $19,000. So that's only 5 of our docs. There's nearly 20, and so you multiply that by 4 and then double it for an entire year, and suddenly you're talking about a little bit of change. The other part of this, of course, is the patient safety part. During this same period of time, we found 1,798 drug interactions. Of those, 66 were the most severe, and 494 were major, and then we got into most of them being moderate or minor risk. The 560 major and severe reactions, again, this is according to the Agency for Healthcare Administration data. They think that maybe 5% will actually happen, because there's a possibility, doesn't mean it happens. And so if 5% of those happen, that'd be 28 of them. And at an average cost of a $4,685 visit to get that fixed, that's an additional savings of $131,000. So I think this is all theoretical, but very possible. We found 781 examples of duplicative therapy, another reason for this system to find that. We wanted to know how much money that saved, and Empower RX wasn't able to give us that, so we hope at some point they'll be able to do that. And then, of course, going back to the question, if you know, boy, things have gotten so bad these days that if you write a prescription that's not on somebody's formulary, it's not 5 minutes till the insurance company starts faxing you back these forms to fill out for it. And to know whether or not it's on the formulary is time saving and certainly money saving. This is getting to be, I'm going to use the word problem in private doctor's office because we really don't have the time to do all of the paperwork just to get a prescription taken care of. You guys were talking a few minutes ago about the liability of not picking up a prescription. Like I said, we only had access to Medicaid data. So we're asking Empower RX to kind of create a back-end report on when they weren't picked up And we're hoping we can get information from other NGOs